So, Dr. Cartner, thank you very much for agreeing to have a quick chat with me.
Thank you
It's
very
been
much,
a long
Dr.
time
Bill.
in the making. I've been trying to track Michaela down for a while. She's very busy, but we've all been very excited about hearing what you've got to say. Okay.
I don't know about that, but okay.
Now, I've promised some people that I'd come and get your take on some things to do with sepsis. Now, I guess sepsis is quite common.
Yep.
I think it harms a lot of people, and I think it's something that is very sort of sexy in that people are always talking about it. There's pathways, there's all of these definitions all over the place that I can never remember. So I thought that what I'd try and do is just to get you a little bit of your insight, maybe ask you some questions about what your approach is, and I'll test some of the things that I think I understand about sepsis, so you could tell me if I'm doing things right or wrong.
Okay.
In your opinion.
We'll both look it up online. One of the two.
So I guess the first thing when we're talking about this is maybe in our minds, when we say we're going to talk about sepsis, what do you think of when somebody says to you, what is sepsis, or what things come up into your mind?
Well, the layperson's definition of sepsis is an infection that is life-threatening or threatens to shut down any one of your organ systems to your detriment.
Right.
And I think that's fair enough.
Yeah.
Let's start with that one.
Yeah, that's nice and simple. So when you approach a patient, what things are you looking for to be able to say, I think this patient has got sepsis?
That's a tough one, because it depends where you are when
Yeah.
you're looking at a patient, and it depends what the patient is.
Yeah.
So there's a lot of difference between you looking at a patient in an emergency department
Yeah.
who's just come in and is
Yeah.
complaining of all these non-specific symptoms, versus a patient in the ward
Yeah.
who is just about ready to go home to rehab, and then you've been asked to see them on a med call,
Yeah.
versus someone who's been in the intensive care for
Yeah.
14 days, has bits missing, has tubes and lines in every orifice,
Yeah.
and you're trying to work out what's going on.
Yeah.
So it makes a real difference what you're looking at and what you're looking for, and that index of suspicion that you have for all three.
Yeah.
And being an emergency physician like yourself,
Yeah.
as well as doing ICU, the mindset is still basically the same for all of them.
Yeah.
And then you've really got to have a big index of suspicion.
Yeah.
Because some patients, they don't want to trick you, but they're sneaky.
Yeah.
And the sepsis doesn't always, or the infection doesn't always appear the same every way, especially when your immune system is compromised.
Yeah.
And not just because you've got not just because you're on chemo or you're on a lot of steroids, like most the textbooks say. Are you a little old lady in a nursing home? Do you have an underlying malnutrition? Do you have a lot of chronic disease? Are you young with chronic disease?
Yeah.
These can modify many of the symptoms that we see,
Yeah.
and they can be quite subtle, so it can be quite hard to pick up
Yeah.
until all organ systems are shutting down at once, and then suddenly it's easy to tell.
Yeah. Okay. Yeah. But I feel like I always think the answer is infection.
It usually
I feel
is.
because it usually is.
Yeah.
So I feel like my general level of suspicion is quite high. And I feel like, having worked with you and other intensive care doctors, you deal with a lot of sepsis. So your index of suspicion is always quite high.
Yeah.
Always thinking about sepsis. Yeah. So, okay, so we're both as paranoid as each other.
It's good to know.
Yeah. So I guess we're going to say that maybe if we can define it so we can keep talking, and people know what we're talking about. So we're going to say that we've got an inflammatory state in the body.
Yep.
That we think is due to some bug of some description, some sort of infection. And we're going to say that when you said it has the potential, or it's threatening, a major threat to the body, so we're going to look for things like their blood pressure, and what other things do you think of?
Sure. Blood pressure's the obvious one.
Yeah.
It can be a difficult one because most of the elderly population are on blood pressure modifiers.
Yeah.
So you've got to work out whether, or they've got a very different baseline. So you have to work out whether they're normally a happy little vascular path that normally sits around 160, 170, and they've got a blood pressure of about 105, in which case that's terrible.
Yeah.
Or are they a tiny little person who's 20 and young, and normally only weighs about sort of 45 kilos, in which case they might only get up to 95 on a good day when they're running hard, in which case they will be they'll be looking absolutely fine at a blood pressure that you and I would think would be ridiculous looking at another person. So blood pressure is definitely one of them, and you've got to have a look at the blood pressure modifying medications and what their baseline is. The other one is temperature, and temperature can be normally pretty easy because everybody knows what's over 36.6. But hypothermia can be worse, and that's more subtle. So a lot of the more severe sepsis actually come to me with a temperature of 35 or worse, or 34. Another side issue, and this is mostly for the guys on the ward who tend to shrug off temperatures on dialysis. But dialysis, or if your blood's going through an extracorporeal circuit, you'll drop a degree essentially. So if you have a temperature of 37.7, which doesn't sound like much, but you happen to be on dialysis, you have to add a degree, so your temperature is actually 38.7. So I see that a lot with the referrals that I get, and it's usually from somebody junior shrugging their shoulder and goes, "Oh, the nurses have asked me to have a look at someone on dialysis. They don't have a temperature; it's just 37, less than that." And we don't really sort of run in young people unless it's 38. But any temperature, no matter how mild on dialysis, or Rigors with or without a temperature, especially on dialysis, they're worth taking notice of. And so these are the tricks that people can underestimate when they're assessing somebody clinically for the first time.
Okay, so we've got blood pressure, we've mentioned temperature, and I guess heart rate is the next obvious thing that we look at. And I guess,
once again, it can be masked by all your medications. So if you're on beta blockers, you may not get a tachycardia, but in young people it's good. Respiratory rate is the most sensitive.
I think respiratory rate's really important, is it? As I'm growing up as a doctor, I'm realising that that's probably one of the more important things to pay attention to, because it isn't modified necessarily by all of these other factors that you've discussed. So
that is the first and it's the best one.
First thing that changes. So do you routinely, is that something that you would routinely look at yourself? Okay.
I find that the history from the patient or the staff, we're talking about inpatients here, is actually not as useful as the obs chart.
Right, okay.
Because the obs chart can give me a much clearer history of exactly when things started to go wrong.
And I must admit, obviously, with my job, I review a lot of charts when things maybe have gone a little bit wayward, let's say. And I often will look at the respiratory rate, and you can see that that's gone up.
And then it goes down.
And then it goes down and stop. And then everything else starts to follow
after that.
And it's just soon after that that the Met call arrives. So I guess I'm glad you mentioned respiratory rates. I think that's important too. So you must be right if we agree.
Of course we are.
So I guess we've sort of framed a little bit about what we're talking about, septic patients. So I guess I exist mainly in the emergency department, so we'll have people, they'll come in, I'll be assessing them. I think they've got infection. Now, I know that giving antibiotics is really helpful, that's often the treatment, not always, but that's often the treatment. And I feel like I have to rush to get those antibiotics in. But one thing that I feel that I didn't appreciate maybe when I was a more junior doctor is that collecting all the samples is quite useful.
Amazing.
And I never see the results, or often don't, but you do.
The day after when they're in the intensive care and you're looking up the blood culture results and you realise that they're not there.
Okay.
That's all right, they've had antibiotics.
Yes, but we're never going to know what caused it.
Not really.
No, okay. So
best guess.
If you had to ask me and my colleagues to do a few things for you in advance,
Yeah.
You'd want us to collect some blood cultures.
Yeah, I know it's awfully basic.
Yeah.
I think the trouble is there's been really, really good literature out there to show that the time delay to antibiosis increases your mortality, and we know that from the Canadian studies, the 7% mortality per hour, and that is true. One of the problems is when you're looking at large population groups is comparing it to your own practice is logistics.
Yeah.
And one of the difficulties in the intensive care department compared to, say, the ICU is in the intensive care department, there's one patient to one nurse.
Yeah.
There is sometimes, especially in some of the institutions where I work, the doctors outnumber the patients.
Yeah.
Not all the time, but sometimes.
Yeah.
And so there is a lot of watching, there's a lot of monitoring, so you know when somebody's getting sick. It's more uncontrolled in the emergency department, and then most of the patients in the emergency, they're admitted, they go to the ward, and then they usually go to the ward after hours, and they're not seen for a while.
Yeah.
So there's a long lag time. So I completely agree. Early antibiotics are good. They save lives. If best guess, empiric treatment, but there's also room in your clinical judgment to make haste slowly.
Yeah.
If you think that the patient isn't going to be seen for several hours because of the way the hospital works, then they may need the cover. Because if they do go downhill, if they do go into septic shock at 2 a.m, no one's going to notice until the 4 o'clock obs are getting taken.
Yeah.
And so most of medicine is a risk game. It's a risk versus benefit. What's the benefit to the patient versus the risk? And when you are first seeing the patient, you're asked to make a judgment in the future.
Yeah.
In ICU, it's a little different in that the future as it unfolds is going to be told to you immediately.
Yeah, that's right.
There's nurse by the bed.
5 minutes.
Yeah, and there's more people more people around. So I understand the logistical difficulties and just thinking we need to get these antibiotics in as soon as possible. Yes and no. Help. It is really helpful if you can to be able to get the cultures first and then give them.
Yeah. Okay. My own personal thing is the urine.
Yeah.
Because we're always waiting for the urine.
Yeah.
And like you say, when you're doing multiple things at once, you don't realise that an hour's gone by and you still haven't had urine. And the other thing is we're talking about patients who are often or were potentially shocked. They're not making much urine, and so that may cause a delay as well.
Yeah.
And so sometimes chasing around after the urine as well, because again, if that's another common source, isn't it? Let's face it, in our population is trying to get the bug out of the urine. So blood cultures, urine cultures, and as soon as you've got that, antibiotics, quick as possible.
If you can.
If you can, okay. I guess the other thing is that the other thing we do in sepsis, we give people antibiotics, but we also give people fluids.
Yep.
Now, I know over the years that we've gone from giving lots and lots of fluids to less fluids to more fluids to I don't know where we're at with fluids at the moment. What's the current thinking on fluids, or what's your thinking on fluids?
Some is better than none, and more is not as good.
Yeah.
It's probably.
Yeah.
It's really, really difficult in that so many decades and so many careers are spent on such tiny minutiae. You can spend your entire life in 7 textbooks on the glycocalyx. But at the end of the day, what are you going to do with the patient in front of you? And the first thing is you want end organ perfusion. And so instead of saying how much fluid do you give and I giving a random arbitrary number, I think we're so used to numbers now, and I realise this is an intensivist talking, so it's very ironic. But you look at the patient and have a look at their end organs and just say, what is the least amount of fluid to perfuse them, or the most amount of fluid without causing harm to the rest of them. We had that conversation last night with one of your colleagues over the phone with a lady with an ejection fraction of 25%, and a gut sepsis. How much is too much? Now for her, wasn't much. But I think the issue is when you're starting out giving fluids, it's not the amount of fluids you give, it's what happens next, which is your follow up. So You cannot, and the other thing is the old anaesthetic rule: you can always give more, you can never give less.
It's very hard to suck it
It's
back
very
out.
hard to suck it back.
Yeah.
Yeah. So have a look at them and go, right, are they an average sort of person? Would I give a balanced salt solution over normal saline? Yes, if possible, I would.
Okay.
However, if all I had was normal saline, okay, I'd be using that. But otherwise, Hartman's is good.
Yeah.
And then I would have, with the exception of the potassium, and the lactate if they're in renal liver failure, and then give a 500 to 250 to 500 challenge and see what their blood pressure does. If it's still not enough, you might give the same or more. If it raises it and keeps it up and you find that they're a responder and they stay responded and the urine starts to flow, this is good. If you're running out of time, you call for help, and then you come on to the other favourite subject, which is inotropes.
Oh yeah, okay, yeah, you're right. And I have had differences of opinion with ICU colleagues.
Awesome. So what are these differences of opinion with my colleagues?
I feel like we don't want to have patients who are hypotensive, who are not perfusing their organs for any length of time. Okay, and so once we've given some fluid, how much fluid, as we've discussed, that can depend on the patient. Okay, we do in a lot of the studies you only get into the severe septic shock category once you've had 2 litres of fluid. And that's okay for studying these groups, but I feel like again that's still probably arbitrary. That might be too much fluid for some people still, but anyway, let's just accept that. But then you have to do something else when you're trying fluids and it's not working. You have to use some form of pressors, and I've felt, we used to only give pressors through central lines with an art line in ICU, but sometimes getting patients from the emergency department to the ICU may take, a longer time than you'd like, let's say. And so we just leave these patients hypotensive for too long, maybe. And I have always wanted to be able to give peripheral pressors. And some of your colleagues like that, some people don't. And so I guess I'd be keen to know what your particular take is on that. I know that you have the ability to put a central line in and give pressors that fashion, so you probably don't need to use peripheral pressors all of the time. But what is your feeling on that?
Well, I think if you've got the total emergency situation, where you've got a patient in front of you and you are really, in very flamboyant language, picking between black end organs, an ischemic brain, an ischemic pair of kidneys versus the potential of extravasation. If that is really your case, then you should pick the risk of an arm and make sure your cannula is really good and start the peripherals. Where I think the important thing is, and so that's the extreme, but most people don't have the extreme. I think it's not about peripheral versus central. I think it's about early communication with both specialties. If you say, I'm losing with fluids and this is the next step, and call the intensivist and say, I'm unwilling to give more fluids, I think the patient now needs pressors. I am inclined to start them peripherally because I don't have the resources. And the resources might be that you're perfectly capable of putting in the central line, but you've got absolutely no time because the rest of the department is going nuts. What? We are all working in a resource constrained environment. If you have an early communication and say, this is what I'm going to do because this is what I need to do next, and then you have a two-way dialogue with the next person. I hate using the words the patient journey, but in the next person on the little patient sort of transfer treadmill, then I think you both can come to a much better agreement than me having a blanket statement saying, don't worry about peripheral inotropes or always use a central line, because both of them are clearly wrong.
Okay.
What do you think?
I think that's the right answer, and I think that we're quite lucky here in that I know that I've got really good dialogue with yourself and Derek and Ian and Shamonti, and so I know that I can ring up and say, this is the situation I'm in. How long do you reckon before we get to ICU? Do we need to bridge this patient with a little bit of peripheral pressure, or are we going to be able to just get them straight to ICU and get going with them? So I don't personally feel we ever really have trouble with that here. I was just interested to hear your
No.
answer.
I don't think so, but
Yeah.
for people who've worked in other hospitals, especially in the public hospitals,
Yeah,
sometimes, and I know that this is probably not what they mean. It's we've had this patient for a while. We put them on peripheral inotropes, and they haven't gotten better, and so
Yeah.
we're ringing you about that. And it always gives me a bit of a smile, because I don't know whether they actually really mean that or not. Because
Yeah.
if they really mean that, then they don't understand how sepsis works. Because I've
Yeah.
never seen it turn around in 2 to 3
yeah,
hours.
yeah, that's
And
right.
so, ringing beforehand to say the patient's, what they're really saying is the patient's going downhill, whatever the next step is.
Yeah.
We're running out of time for now. You're part of the next step. Be involved in the conversation.
Yeah.
And that works better for everyone, I think.
Yeah, I agree. Okay, so we haven't got much time left because we don't want to bore people to tears, but I just wanted to ask you one other thing,
I'm pretty amazed if you've made it this far.
which you may or may not have an answer for this one.
Okay.
We need to use lactates
Okay.
all of the time for every patient who may or may not have sepsis.
Yeah.
Do you
Thank you, Rivers.
Do you agree with that statement, Dr. Cartner?
My personal statement is that it's a wonderful research tool because you can't argue with it.
Yeah,
However, for clinical acumen, what you're looking at is the end product
yeah,
of anaerobic metabolism.
yeah,
And so it certainly can give you a clue as how fast you're going down the rabbit hole.
yeah,
But if you're relying on it to make a diagnosis,
yeah,
you missed the boat in the first place.
yeah. Okay. Probably need to go back to medical school.
Yeah.
Maybe. Yeah.
They're not sick. Their lactate's not up.
Yeah.
Is really not something that makes any sense.
Yeah. Okay. Yeah. Okay. And so I've gone through different phases. I've gone through the phase where I used to like to do lactates on patients, and I must admit this was when I worked in the public hospital, and I was probably thin slicing a bit more. And
What do you mean by thin slicing?
or just where I didn't have as much time
Yeah.
to make my decisions,
Yep.
and I was dealing with a lot of competing interests at
Yeah.
the same time.
It is a red flag.
And I was I was listening to stories from juniors about patients, and I'm thinking that doesn't sound too bad. If the story that didn't sound too bad came with a lactate of 5,
Yeah.
I would say, hang on a minute,
Yeah.
we need to go back and look at this. But
Yeah.
if the story that didn't sound too bad came with a lactate of 1,
Then your spidey sense wasn't
my
tickled.
spidey sense wasn't tingled. But now that I'm seeing all of the patients myself, I feel like that I'm replacing that test with my own clinical judgment,
Yeah.
which we're all allowed to be wrong, and sometimes it can be very, very tricky in our population with all of the things you discussed earlier. But I feel that they very rarely contribute much to my decision-making process. And the other thing is, I also think, well, if I just do one now, what does that mean? It's only a point in time. If I'm going to repeat it maybe in 4 or 6 hours time when they've had some treatment, if I think they're quite sick, but then the lactate is getting better, then they're getting better, and if they look like they're getting better as well clinically, then that makes me happy.
Yeah.
But I don't see it being as useful, I guess, in our setting.
Yeah.
Because,
I have never refused an admission to intensive care solely based on a lactate.
right, okay. You've asked some other questions.
I've asked
as
some
well.
other questions as well.
Okay.
So it's nice to have it.
Yeah.
It's not essential.
Yeah, okay. Good. All right, now I think that we should try and wrap things up now.
Okay.
I think we've had a nice Dr. Walters, Dr. Cartner, waffly roundabout discussion about sepsis, which I've enjoyed getting your insight as always. Do you think there's anything else that you feel that people don't seem to understand, or that you'd like to express, or anything else that we haven't discussed that you think is super important in this setting?
I think in our wide-ranging talk
Yeah.
on diagnosis and management and inotropes,
Yeah.
I think the only thing that you have to round off any talk with is it is all a waste of time without source control.
Yeah. Okay.
If it is fine to have supportive therapy, but without source control, everything, including the best antibiotics known to man, will fail.
Yeah.
And by the way, are failing.
Yeah.
We're running out of options without source control. And
Right.
so, not to forget that is the end game
Yeah.
in the sepsis
So
story.
when you say source control,
Mhm.
we have to do that in my house at dinner time when everybody's putting far too much tomato sauce on the lovely meal that I've cooked. But
Yeah.
what do you mean by source control?
It means that if there is any place that the infective organisms are hiding, which means either deep necrotic tissue or obstruction, then it has to be drained or lanced.
Yeah.
So that you can get the antibiotics to the source.
Yeah.
So you have to stent it, drain it, cut it out, or find it in the first place.
Yeah. Okay.
And that's it.
Good point. Excellent. Thank you very much for taking the time. Hopefully we'll have another chat about something else equally as interesting
That's right.
at some point in the future.
And I'll try not to giggle.
Thank you.